based care. Over to yourself, Susan.
Okay, thanks very much. So the title was Coalition, okay, and particularly in relation to policy. So I've had a history of working for the Department of Health as a nurse in midwifery and child health uh, advisor, but also worked at the operational arm of the HSE as at a corporate level. So that's what I'm going to bring to you today. So my title is Implementing Policy and Coalition Building in Real Life, what it really takes and what it really looks like. So today I want to speak not about promises, but about what it really takes to redesign and implement health services, the benefits when it works and the conditions required when it's difficult and hard. After many decades working across health systems, including practice, government policy, education, and corporate HSE, and international reform, one thing remains clear: implementation is the real politics of healthcare. It's where vision collides with complexity and where strategy must survive resistance. Ireland doesn't lack reform frameworks, it lacks consistent follow through. That's why I say this. No innovation or redesign is implementable without coalition building across professions, across politics, systems, unions, and the people they serve. Let me ground this in real lived policy work, some celebrated, some shelved, and all instructive. So the first one I want to talk to you about is the Performance Achievement Policy and Framework. In 2013, the government agreed with the unions in Ireland to a pay deal as long as the HSE implemented a performance achievement framework for all of its staff, which was 130,000 plus. But the agreement had never been activated. I led the development of this framework in 2011 before the deadline. And this policy marked a shift away from punitive performance reviews toward a culture of continuous learning. We didn't just write a policy, we built the infrastructure to implement it. So we had clear national framework. We also had corporate support, which was critical. We had implementation guidance, a resource forum with KPIs, and a monthly reporting structure to corporate HSE. We also developed a comprehensive online training and learning platform with a programme for staff, which was delivered through our CPD educational portal for the HSE. To progress this work, we had to re-engage the unions, and yes, they wanted something in return, and that's coalition building, reciprocity, relationship, and reason. We listened, we negotiated, and we accommodated a parallel concern of theirs, and in doing so, we were able to build trust. Another example now of policy was I led the development of what we call a geo-aligned recruitment model. So I led a redesign of the recruitment and hiring model for the whole of the staff of the HSE, especially clinicians. It was strategically sound. It was union approved in 2019, but after that, it sat dormant within the HSE. Now, why did this happen? Because although everyone around the table had signed off on it, the will to implement simply didn't translate into practice. Unlike the performance achievement framework, there was no overarching system or dedicated resourcing to drive it forward. So then what happened? COVID-19 pandemic hit and the HSE had to act. In 2020 and 2021, the model was activated out of necessity. Suddenly, staff were being recruited where they were actually needed, locally and not from a central port as was happened before, without waiting weeks in limbo, weeks that often led to them finding jobs elsewhere in the system. And it worked. It aligned workforce planning with population need efficiently. Was it fully evaluated? No, it was not. But that's not a failure. It's a missed opportunity for learning. And the third different example I want to talk about was that I actually led in the Department of Health a policy called Integrated Community Model of Care for Nursing and Midwifery that I developed, like I say, in the Department of Health. This wasn't just another policy document, it was co-developed in deep partnership with the nursing unions aligned with international best practice and built for 21st century home first care. It was approved, it was ready, but just as we prepared to move from design to delivery, a broader industrial dispute emerged and corporate HSE halted the implementation of this policy. Not because the model was flawed, but because politics got in the way. The cost of that delay wasn't just policy paralysis. It was care delayed. It was
30
progress
seconds.
deferred. And yet, then in the December 2018, the Department of Health were required to develop a scalable community-based solution and action plan for the Sláinte Care strategy that very same model was quietly and quickly resurrected. It fit, it worked, because the need finally outweighed the noise. But imagine what we could have achieved if it had been embedded earlier. So what do we learn? That implementation isn't the end, it's the engine, that coalitions aren't optional, they're the currency, and that relationships, even reciprocal, complicated ones, must be maintained with courage and consistency. We must stop designing for policy approval and start designing for political durability. We must stop confusing agreement with action, and we must stop letting system disputes cancel solutions that actually could fundamentally save lives. Ireland has the frameworks, we even have the policies. What we need now is the coalition courage to implement them consistently, accountably, and above all,